Imagine from them, they get to see someone that spent 5 weeks in their NICU now practicing with them.
It's the most rewarding thing that it can happen. We see children that we leave, but they left the NICU coming back when they turn 1-2 years.
They're now resuscitating 22 and 21 week babies. I have very strong feelings.
Girls do better than boys. We are not very good at being born preterm.
I'm a very, very big believer in patient autonomy. They're going to choose to do whatever they want. But we have to inform them and then they make the decision. Hey guys, welcome back to my podcast. I'm here with Dr. Gaston Ofman. He is a double board certified in pediatrics and neonatal pediatric medicine. He's completed his medical degree and honors in how do I say that?
Neurodevelopmental University. Yeah, you got it.
In Buenos Aires, followed by his pediatric residency in the University of Texas Southwestern. He then pursued an advanced fellowship training in neonatology in Northwestern University, and now serves as a founder of Subbeam Pediatrics, a concierge pediatric practice offering holistic and personalized pediatric care. Welcome and thanks for coming today.
Well, thanks for having me.
Cool. The main reason why I want to have you on is I'm doing this podcast and I'm doing a bunch of other interviews, mainly to help educate my patients on things of OBGYN, but also practices around our field that are tangential, but something I may not be able to give them the best information on. So you have a special field of neonatology, which is dear in my heart. I was born 30 weeks. And a lot of patients ask about, for example, in our hospital, the quality of the NICU, for good reason, is as good of a doctor as I am, things can happen, and having a good neonatologist, a good NICU, good resources are really important for continuing that practice. So I just wanted to talk to you, what got you into neonatology in the first place?
Yeah. First, let me echo what you said. I think this is a continuum of care. You guys see the fetus and the baby development, and then we come in as as a continuation of that care, because as you said, as it happened to you, you were born before your full development in the womb. And if we can't understand what happens during the pregnancy, understanding your expertise, we can't really treat the babies when they're born. So I'm happy that we're talking about this. Myself, I did my medical school in Argentina, and then in contrast to the rest of my medical school colleagues that went into residency, I had the bag that was more interesting in research. So I was lucky to be connected to a researcher in Neonatology, Cincinnati Children's, where I spent some time with him, about 2 years, studying lung development in preterm babies, which is the main problem of being born before time. And I got immersed in that research in the world of discovering things that we don't know, and also in the world of innovation, because neonatology, as you know, it's a fairly new field. It only has 50 years since the Kennedy's son, that was born also preterm at 35 weeks, passed, and the president by then invested all this money in trying to innovate and discover how to save babies' lives that are born preterm. And this is a perfect combination of investing in innovation and the actual translation in how a field is born and how lives are saved. Because before that baby passed, there wasn't any investment in research in neonatology. And then suddenly, babies that are born preterm started surviving. Again, in these 70 years ago. And now babies as young as 22 weeks, 21 weeks gestation of a 40-week complete gestation survive. And when I was doing research in Cincinnati, I was seeing the effects of studying a small cell, then studying an animal, and then studying a bigger animal, and then studying humans, and then saving life. Was, wow, this is mind-blowing. I say, well, I love this, a combination of doing research, but also doing clinical care and being with patients and families. So then I did my training in pediatrics, and then I naturally followed the training in neonatology.
Incredible. It seems like for you, what I'm getting at is your main interest was in neonatology to begin with, and embryology in general, and just research and the beginning of life, and how can we extend the womb once they're out.
That's right. Yeah, that's exactly right. So, and how can we extend it? Trying to provide the best long-term outcomes, because first we try to improve mortality or avoid babies' deaths in a way. And then where we get to that stage and then babies leave the neonatal ICU, then they go to the pediatrician to follow up and we see the consequences of having survived so early, so being born so early. And then we start to realize how to improve the quality of life, which is what ultimately we all want as caregivers. And yeah, so that is very, 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 very motivating and interesting to me. And after being in neonatology for several years, I said, well, I really miss the connection I have with patients when they leave the ICU because
Mhm.
you were probably in the NICU for a few weeks, and then you went and saw your pediatrician and asked the neonatologist stop understanding what happens after they leave the door. That's what motivated me to open the practice of more concierge developmental focused pediatrics.
Yeah, I definitely want to get into that for a little bit. But interestingly, as far as continuity of care, believe it or not, I practice in Mount Sinai. I was delivered there, and the two neonatologists that took care of me still practice. So imagine from them, they got to see someone that spent 5 weeks in their NICU now practicing with them. And I practice also with my father, so it's very it's a beautiful thing for them to see that, and actually for me to tell my patients, hey, they took care of me. There's always risks to having a baby preterm. I have a small belly button, but otherwise I did okay ish. I'm here
Yeah,
taking care of you. So
it's the most rewarding thing that it can happen. Yeah, we see children that we leave, but they left the NICU coming back when they turn 1, 2 years. We have yearly NICU gathering, and when babies are left the NICU come in. So I can't imagine being the neonatologist that were at your birth and seeing you now so successful.
yeah, there was a few things I went into that on a personal level. My mom, I have a twin brother, so we're gonna transition into preterm labor and preemie care. So imagine
Okay.
I'm a twin. This is gonna bring you a flashback. Don't freak out. My mom's mom took DES with my mother, who had a T-shaped uterus and an incompetent cervix. So imagine
Wow.
the setup for they tried for a long time to get pregnant, then they got twins, and this is my strange transition to what are the main causes you find for preterm labor and having a preterm birth that brings babies
Yeah.
into your NICU?
So you said medications and environmental factors that can affect maternal or I guess fetal development, womb development, uterus development. And truly the number one cause is unknown. We still don't know what
Mhm.
causes preterm birth. If they at one point find out, then I'm out of my job, probably. But we don't know. But we see together, you as the obstetrician and me as the neonatologist, mothers with risk factors. What are those?
Mm.
So commonly, are we see a history of having a preterm baby is one common risk factor for a mother coming in pregnant that had a history of a baby born at 28 weeks. So we kind of an alert on that one. Then other common risk factors is gestational diabetes, gestational hypertension that affect fetal development. So the fetus main supply of nutrition is the maternal through the umbilical cord, through the placenta. So if mom has any medical problems that can affect the blood vessel development or the vasculature development, it directly affects the fetal development. And we know that those women at a high risk of delivering the babies preterm. And yeah, and really the unknown reason of preterm birth is the main underlying cause.
I think
Outside
that's
that,
yeah, I think it's a interesting point here. Just a segue here. If we're going into preterm birth, there's two main causes of preterm birth as far as You can go into preterm labor because you have something that causes you to go into labor. You can have an incompetent cervix, you can have an infection. But on the other end, you could have a medical condition that may require you to have a baby early. So you mentioned a few things like hypertension, diabetes. Those things may put you give you some reasons to go into labor early. But we also, as an obstetrician, may have to put you into labor early because we have to weigh the risk and outcomes of, hey, we need to have a baby now because the risk of staying pregnant is higher than having a baby now. And then the advantages of NICU care allow us to make a safer decision. And the main thing I want to get out of this is no matter what you do, understand if you have the ability to deliver in a place with a good NICU, you're putting yourself so much steps forward than a place that does not have the ability to take care of you.
That's right. So I agree with that, because when a typical example that I see is mothers with fetal growth restriction, where their babies are for some reason not growing as expected because of blood flow problems or blood flow delivery problems to the babies. And we get together with our OB colleagues and discuss these cases. So how are the babies growing? How is the mom? Is it time to induce the delivery? Is it time to bring the babies outside the womb? Because perhaps, as you said, the the environment outside the uterus is less damaging than still remaining in the womb. So yeah, that's a common case where collaboration between the NICU and the OBs are, I think, positive for the ultimate outcome of the baby.
Yeah, it's true. Us, the high risk doctors, we sometimes have to sit around and figure out, hey, there's ideally what the ideal situation, but also the situation that we have. And luckily, where we are, we have ideal situations as far as NICU care and as far as high risk medicine care. But different parts of the country, and I like people to know also, if you're listening to this in a different country, the risks and benefits in your country, in your situation, may be different than ours. So, for example, you said something in the beginning of this talk. They're now resuscitating 22 and 21-week babies. I have very strong feelings, by the way, not towards that, but which we can talk about, but as from a practical standpoint. But my point is, we have the ability to intubate a 22-week baby. Some other countries may not have that. So I just want people to hear, if we say something here based off the situation we're in, where you live or where you're practicing, that might be a little different.
Yeah, that's right. I'm sorry. Go ahead.
Please.
No. And just to build on that, not only outside the US, those differences in outcomes happen if the baby is born in a level 4 NICU or most advanced NICU or not. So here in the US, if the baby, I used to practice in Oklahoma for a few years, and the main children's hospital was in Oklahoma City. If babies were born, for some reason, the mother didn't have time to travel all the way to Oklahoma City and was born in a tertiary care center or a less complex center, then the outcomes we know are worse for the babies and for the mothers. So you're completely right.
I had the unique opportunity to train in Jackson here, and because it's the biggest hospital as far as in Dade County, South Florida, but also happens to be the hospital closest to the Keys, to the Bahamas, I would have to run to the jet pad with these people in preterm labor, 22, 23 weeks. Sometimes we didn't know their gestation. I'll call you guys over, figure it out. So it's lucky when we already have access to the patient here and we're not scrambling on the ground. So the outcomes are just better. We know what we're talking about. And that also goes into the next thing when we're talking about preterm babies, is we have two things. We have the size of the baby and the age of the baby. So I'll have you discuss the differences of that and what matters more.
Yeah, so both matter equally, I guess, if you have to arbitrarily assign a weight for each of them. That's why, it's hard to put in labels of outcomes based on a gestation. There are different factors that we use to predict how well a baby is gonna be or is gonna do if born preterm. The weight and the gestation rates are two main things, but then the sex. We know that girls do better than boys. We are not very good at being born preterm, except your case. You have an outlier there, but girls do much better. And then We know that the maternal risk factors matter. If mom had an infection and the baby was born early, we know that puts the baby at high risk of having an infection. So going back to the gestational age and weight, that's a moving target. That's a moving target. Again, about every 5 years, the week of how early a baby can survive goes down, because the innovation and the medical care and the OB care gets so much better. So we know that babies, as compared to 30 years ago, babies that are born from 35 weeks and above do extremely well, do very, very well. Babies that are born from 30 to 35 weeks tend to have more respiratory complications because their lungs are immature and not mature enough to breathe without problems. So they need breathing and support and breathing help.
I blame my lack of cardio based off that. It's that, or I just hate a treadmill. But I blamed it that I was 30 weeks.
I think you're beyond the window where you can still blame your mother, basically, because
my twin was a natural athlete. So there you go.
Who was discharged first? This was the question.
I don't know. I was 2 ounces bigger. I was 3 pounds, 3 ounces. So I was also technically growth restricted. We're in the 8th percentile the whole pregnancy.
Oh, wow.
Yeah.
Yeah. Twins are hard, 35 weeks, you said that you were
30,
born?
30
30 weeks. Okay. Well, that's pretty, again, it's better than 28 because we're talking about gestation, and 28 weeks, about that ballpark, is when the risk of having long-term medical problems such as breathing problems, that's the main thing. Then neurodevelopmental problems, cerebral palsy is very common in babies that are born preterm. And when we hear the term cerebral palsy, we think perhaps what my perception of what people think is the most extreme form of cerebral palsy, which is our children that can't really walk, that can't really talk, that they have severe issues of motility and mobility. But it can be, between mild cerebral palsy, just a stiffness on fingers of an arm, to severe cerebral palsy, which babies are born closer to 24, 25 weeks can have. But we don't know. We don't know because the medicine is changing so fast that babies that are born surviving at 24 weeks and now 5-10 years have different care that the babies that are born at 24 weeks now.
Mm-hmm.
So we're just starting to understand the long-term effects of the neonatal care early on. But 28 weeks, I would say that if someone has to remember a barrier of when you're almost out of the woods, it would be between 28, 29, 30 weeks. And then again, this is considering other very important variables.
Yeah, and for the patients that will listen to this, when we are making these decisions, usually the obstetrician's making this decision based on what is happening. Usually I'll call him up. Hey, Gaston, hey, there's a baby here. I think you need it. And you're like, how many weeks? What's happening? But just so you know, the algorithms that we use are to optimize the risks and benefits of these situations. So yes, 28 weeks is great. 32 weeks, you don't even need magnesium for neuroprotection anymore. So everything we do is, when we're dealing with a medical situation in obstetrics, is balancing, hey, can we cook this baby in there longer because we know it's beneficial versus the risk of staying pregnant. So a common example, since we're talking about preterm birth, is what happens if you break your water. You break your water and you're 18 weeks. We have a very different discussion if you break your water at 25 weeks, 34 weeks, 37 weeks. The time of delivery may change, and that has changed. A big thing when talking about really preterm babies, midway through my residency, let me put it this way, a 22-week baby would come in preterm labor, and we'd have to tell the mom, I'm so sorry for your loss. And then halfway through, about to go say, I'm so sorry for your loss. And the NICU would come and be like, wait, let's talk to them. Let's see what we can do. And that was a huge shock for me. And because it was so new, because it was on the bleeding edge, the way patients were counseled changed, but also the way our guidelines also changed. If you had a 22-week baby, we would not offer them steroids and magnesium because for our guidelines, it was against protocol. That changed within a few days of having, because we'd have to have a conversation from the obstetricians, the high risk doctors, and the neonatologist. If we are going to resuscitate these babies, what can we do to maximize our outcomes? So for these, how do you counsel these patients that say break their water at 22 weeks?
Yeah, yeah, that's right. I mean, I think you said the word consensus. Yeah, and that's important because each specialty, each expertise has different backgrounds, different knowledge. I think the first thing is each center, as we discussed earlier, has different abilities to care for these babies, right? Each country has different abilities to care for these babies. So all the specialties come together, share their background and share their knowledge, and then include the demographics of the area. You know, what are we experts on? Can we do this on babies that are this weight, this age? Do we help them or can we? We need to improve before offer. So that's the first step. Understanding the human, intellectual, and material resources that that we may be able to help. And then knowing that there's a consensus of saying, no, we do have to draw a line somewhere. But that line nowadays, ethically speaking, at least in pediatrics, has become a little bit more blurry
Mhm.
because there is a trend towards counseling families and parents and mothers in the risk and taking a shared decision with them, having them giving them the information that we know as experts and understanding what would be best for their situation and for their scenario to them take a joint decision. To do an example, for instance, a baby that is on the, we call it periviability zone or area or weeks, that for a few days may not survive, but then after a few days, it's a baby that can have the lungs developed enough to survive and perhaps go home after the NICU. But those babies have almost 80% chance or more of having severe brain developmental disorders, and also have 50% or more chances of not surviving the NICU, of dying. Now, because the risk of severe outcomes of these babies are so high, then we don't just take for granted that we need to help this baby, and we sit down with the families in conjunction with the MFM and the OBs, and we tell them the information that we know of what happened with the babies in that center. And with that information, then we talk with the parents. So some families would say to us, under these circumstances, I rather, we just do comfort care on the babies and we hold them and we let the baby pass. And that's the most peaceful way that they
Mhm.
imagine that the baby's end may come. But some families would say, I've tried 7 times to get pregnant. This is really my last chance. I understand that the baby may have all these issues, but I'm ready to, provide all the love and care for this baby, regardless if this baby is able or not to walk or talk. And that has become, acceptable because that's what would make the families and ultimately the babies happy, because quality of care is also very subjective. Before it's not running a marathon or going to Harvard. It's just it's a combination of things that are very intangible, but are add up from family care, health care, and and some of these families will provide that care to the baby, even though they develop these severe complications. So it's a long answer, and I'm sorry, but it
No,
is a
but
complicated subject.
it's justified for a few things, because there's something you touched on. It's you need to have a group decision making with the parents, and that is one of the hardest things to do because it is a severely high emotional moment. People's backgrounds are very different. For me, where I trained, it was a more undereducated, very highly religious community. So that was very hard because it was hard for them, and sometimes there was language barriers. We had some patients from like Guatemala who didn't speak Spanish; they spoke like Mam Quiche, so we couldn't even find a translator for these people. They would come in, and then to first of all, for them to understand the difference between what you basically touched on is survival, but versus intact survival. If they're 40 years old, to put this in more perspective, a lot of these kids, because some people are like, comfort care, what do you mean? Just let them go. Like for the people who are saying, do whatever you can. When they're 40 years old, you will be brushing their hair. You will be changing their diaper. You will, so to put in perspective what that quality of life would look like, maybe what that person, the parent going in there, is that a quality of life that you want to push out through as a human being? Are you someone that can do that for someone else? And is that really helping that person? There is no right answer to that question. And it's such a high stakes situation because usually these decisions need to be made on a time span. This is not something that we can give you weeks. We're having this conversation because we don't have weeks. We need to make a decision. Someone could be 22 weeks in laboring and the baby's breech, and we need to decide, do we need to do a C-section? Do we classical the uterus, make you not able to have another vaginal delivery ever again? For what chances? And that is one of the hardest decisions, probably one of the things for me in residency, because that change happened while I was in residency in our institution. That really burned me out. I would do NICU rounds very often in the NICU to see how these babies would do. And honestly, most of the time it broke my heart.
Yeah, no, it's so difficult. It's so difficult. And yeah, for me also struggle, but I think that because medicine changes so fast, we just need to keep an open mind. And for me, during neonatology, where even in my training, the weeks of survival was around 24. When we was born at 24, we would just look at each other saying, what are we doing here? Are we pushing the limits? But now babies at 24 weeks struggle, but many of them do well. We see them going home and we see them having a happy life with their families. So these decisions are so difficult and so rushed. But the shift from a more paternalistic medicine to a more, I guess, shared decision making, I think is ethically better than us deciding what to do. That's my
100% agreed. It's because we are also human as practitioners. That was one for me on a personal level, to be able to sit back and just not bring my bias to the table was very hard. Yeah. And I don't envy you for having to be the person holding the reins for that conversation.
We're all biased. We just need to just recognize, what's my tendency? My tendency is to say this or not say this. And then try to recognize that and work on that. But it's rough. And, similar things happen not only with preterm babies, but with babies with other genetic disorders. That before, tries to me, babies with Down syndrome, now, no one would think about not offering a surgery or, helping them with feeding tube. Before it wasn't the practice. And things that are happening with babies with other more severe genetic disorders. But I think it's a very interesting field, and perhaps for many hours of discussion. But thank you for bringing it up.
Yeah, so we spent a lot more time on that than we thought we would. But kind of slightly going into that, what are the roles of steroids for these babies that are preterm?
Yeah, so steroids are a game changer in neonatology. Before steroids, there was no much chances of this baby surviving. And this is another successful research story. And it was a more serendipitous finding of the researchers, giving steroids to pregnant sheep that this researcher was investigating how steroids, I guess, was the role of steroids in pregnancy. But he noticed that when he took the babies out earlier, because it was part of the experimental design, the baby sheep that were taken early survived and were breathing much better than the babies that from mothers that didn't receive steroids. And then it went on to the 60s and 70s, where steroids, after several clinical trials, became part of standard of care for mothers at risk of delivering a baby that is born preterm. And the main effects are in accelerating the lung maturation and lung development of babies that are born preterm, which, like we said before, is the main complications. Babies, when they are preterm or when they're in the womb, the lungs are filled with fluids. And when they are suddenly born, that fluid needs to be reabsorbed, sucked in, and it needs to be replaced by oxygen and air and gas for the oxygen exchange and to deliver the oxygen to all the organs. But babies that are born preterm have difficulties in this because they lack substance that is called surfactant. And because their lungs are stiffer and more puffy in a way, or more edematous. And the steroids given at least 24 hours before the babies are born helps us a lot in the NICU to help these babies breathe. So when you guys talk to us and say, this mom is going to deliver this baby early on, the first question that we ask you is, have we given steroids or not? And when you say, no, well, she just came in, then we start, scratching our heads. So, well, okay, all right, okay, we'll figure it out. But if we know that the mom receives steroids, then that we know that the baby is gonna do much better. Not only early on, but also long term. These babies, when they leave the NICU and go to their pediatrician, they have much less respiratory problems such as asthma or bronchiolitis when they grow. So this is actually a miracle of research that nowadays there hasn't been in neonatology field something that has changed the outcomes so much. Yeah,
it's incredible. That's one of the few things we really try to keep people pregnant for, still, just for that reason. Sometimes it gets a little more confusing if we have a really diabetic patient and they're going to deliver soon and their sugar is like 200. Do we give them the steroids? We usually can't. It gets a little more whatever. So it's always a group decision making, but no, it's crazy, especially through 34 weeks, even some literature up to 36. Sometimes we rescue them after 36 weeks if they haven't got it before, because it's been so helpful, even for those late preterms. Going more into the late preterm stuff, generally in your hospital, is there a certain cutoff on when babies go to the NICU, or do they just stay with the mom? I know some places it's 37 weeks, some it's 36 or 35 weeks.
Yes. So in our hospital, less than 36 weeks are automatically admitted to the NICU. And babies also that are weighing less than 1,800 grams also are admitted to the NICU. These are babies that are at high risk normally for breathing problem, but also the other preterm related problems, which are mainly temperature regulation. So they can get cold very fast, because the brain is the one that manages our thermoregulation, the temperature regulation, and brains of babies that are born preterm do not do that very well. So they get cold, and if they're in the newborn nursery wrapped, even though the nurse comes in and checks the vital signs, we may miss that they're getting cold. And the other thing is sugars. So the hypoglycemic, they're sugar drops, because the sugar stores on babies basically is transferred from the mom through the placenta on the last 4 weeks. So if a baby is born at 35 weeks and not at 40, then the glycogen stores, the glucose, the sugar stores are much less. So these babies that are born at 34, 35 weeks, which are truly the most common preterm babies, have risk of having low sugars. So babies that are born again at less than 36 weeks, less than 1,800 grams, they come to us, may stay with us for 1 to 2 days, and we'll say, okay, yeah, all good. We can go with mom or stays for a few more days.
Currently in our hospital, we actually have a pretty strict 37-week cutoff, which is a little conservative in my opinion, but safety first. And we were talking before, every hospital has a different protocol. Sometimes I try to nudge them. Sometimes they go for 12 hours and come back. But that's something we're working on changing. It's a little old school, but I mean, you don't want a hypoglycemic baby, and you don't want those complications for prematurity, which makes sense too with the growth restricted babies. And also most of the growth happens the second half of the pregnancy, the third trimester, the growth of the baby. Most of what they're getting is at sugar stores in their liver that are really making the baby grow and basically deal with the process of labor as well, like to be able to combat the hypoglycemia. So before they come out, sometimes we see more issues because they can't deal with labor as well because of the blood flow, and because if you think about it, if you don't have a glycolytic system, because you don't have that regulation, a lot of time they don't do as well, and that causes some other issues. Which brings us to something else we kind of wanted to talk about, was C-sections.
Okay. Yeah.
From any advantages, disadvantages of having a C-section from your end?
Just more than I will. We know that the external fetal monitoring has improved so much. not going to comment on that with you here because you are the expert, but sometimes babies are better outside the womb than to stay in the womb, and sometimes the C-section is indicated. But there has been a rise in elective C-section with not the medical indication that doesn't outweigh the risk of having a C-section. From our perspective, as a neonatologist and pediatrician, we worry that without the natural labor, that babies will have what we call transient tachypnea of the newborn, which is breathing fast after being born, after a C-section without labor, because of the inability or the lack of absorption of that lung fluid that we talked about before. Babies are born with fluid in their lung that needs to rapidly be exchanged with air. And when babies are born through a C-section, that process is slower. So we many times have babies in the NICU that are breathing very fast. They need help to breathe. And it's because they were born through a C-section with or without medical indications. But that's very common, and that's called respiratory distress syndrome. And I think it's a good topic.
Yeah, I think we personally push our patients pretty strong for vaginal delivery. Again, we're talking about group decision making and autonomy. We have a lot of patients from South America, from Turkey. That is a very strong conversation. A lot of them adamantly refuse, no matter what we tell them, for vaginal delivery. But there are risks both ways, and that's one of the things that I tell them. Labor is extremely stressful. Every time the uterus contracts, there's no blood flow to the baby. But stress is sometimes good. If someone exercises and they're healthy, they feel better once they're done exercising. If you're in horrible shape and you bring your friend, or you bring your friend who's in horrible shape and you go to work out with them, you're going to feel amazing and they're going to throw up on the floor. So one, in this case, baby, would benefit from a vaginal delivery. They'll get the benefit. They'll get the rise in cortisol. Probably, I don't know if there's any relationship there as with the steroids go. They're going to literally get squeezed out of the vagina, which is helpful. They literally wring out their lungs, and they tend to do better. So an ideal situation for mom and baby. So some moms go, I think for me, it's better to have a vaginal delivery, but I want a C-section for the baby. I don't want stress. But it's like having a kid and locking them in the room and never letting them explore the world, right? The stress can be good.
Absolutely.
So that's another conversation we have. And then there's risk both ways, especially when we talk about with the C-section, a lot more risk to mom surgically. So specifically, if it's a repeat C-section, third C-section, we don't even need to talk about placenta previa, placenta accreta spectrum. Then we start having babies a lot earlier, and then with a lot more danger to mom. But it's good to hear that on both ends, we both push for vaginal deliveries, because from your perspective, it is also better for the baby if they can handle labor.
Absolutely. And there's one more thing that we are starting to understand now about the benefits of vaginal delivery, which is the effects of being born through the vaginal canal and the vaginal flora, the healthy bacteria, helping the baby's skin flora, which is beneficial for the immune system. So now there are lots of studies about the long-term consequences on the baby's immune system because of being born vaginally. So I think the body is smart. We are born to deliver vaginally, and when there's no strong indication for a C-section, we see the consequences.
Yeah. And what's interesting too on that note is they've taken that literature and they've tried some strange things called vaginal seeding, where they try to take the vaginal flora, and it was a disaster. The babies got sick. Where they try to literally take the vaginal microflora, and bad idea. Sometimes I get questions, but hey, if I have a C-section, I know there's this benefit. No, it didn't work out. The baby's too bad. So I wonder how specifically in the future, if they're able to bridge that gap of, if for someone that needs a C-section, if they can get those benefits.
Yeah, I don't know. Hopefully it will.
Yeah. Another main thing is we try to do our best with these vaginal deliveries to get baby directly on mom's belly and do like skin to skin care. One of the things that sometimes distress the patients is I tell them, hey, their water breaks and I see that the baby pooped. And I have to tell them, hey, The NICU doctor is going to have to come and assess the baby, and they may have to take the baby over to the warmer to get checked out. I tell them there's risk that they can swallow it. Most of those babies do okay, but if they aspirate, it could be a problem. Maybe you can touch a little bit on meconium aspiration.
Absolutely. So meconium is for our audience that are not familiar, is the first stool, the first poop of the baby when the baby is born. But some babies have that stool before they are born, especially if there is some degree of stress on the baby. If the blood flow is not getting to the baby adequately, or the baby is stressed from birth, then that stool can come out and get mixed on the amniotic fluid, and the baby can sometimes, about in 5% of all those episodes, aspirate it and inhale it before the baby is born. That substance, the meconium, is thick. It's like petroleum thick, and that can get stuck in the small airways at the end of the lung. And when it's stuck, the air can come in, and that's something called meconium aspiration syndrome. Now, before, we as neonatologists, every time there was meconium, we go in and aspirate the meconium in the airways, and now we're starting to get a little bit less aggressive on that, but it's still a problem that we see. And that meconium not only blocks the airway, but also causes inflammation in the lung. So many of these babies, as I said, about 5%, they come to the NICU and need breathing help. Yeah, so there's a lot of research in how to prevent the inflammation of that meconium when babies come in. Much of it comes from surfactants, and we give surfactant not only to preterm babies, but also for babies that have this meconium aspiration syndrome. Most of the babies, Mitchell, they go back to their mothers only 1 or 2 days after they're born. Some of them can get pretty sick and go into not only affecting the lung, but causing something called pulmonary hypertension, which is affecting the blood vessels that go through the lung. This inflammation not only blocks the lungs, but also blocks the blood flow that goes through the lungs, and is a number one cause of babies going into something called ECMO or a pump, a heart pump.
But just to clarify here, just because your baby had meconium doesn't mean they aspirated. They most likely did not aspirate. What he's talking about specifically is a complication of the baby aspirating, which is why we have them there, and that's why we have a team present, just in case.
Absolutely. I think it sounded more alarmist than anything. Most of the babies do fantastic.
Yes.
They have these meconium, they cry, they go with their mothers. Less than 5% will have some breathing problems. Most of those will go back to their mothers and fathers with no issues. Only the minority of the babies, which is what I see. So perhaps I'm a little bit biased. They come to the NICU and they need our help.
But I'll tell you, I had a patient. She came to us. We do a lot of natural births. We believe very strongly in physiological birth. If obviously we feel our job as obstetricians is to let the mom do whatever she wants as long as it's safe, and we put a safety net. If there's a medical issue, if there's an intervention that needs to happen, then we intervene, right? So we don't want babies born after 41 weeks because there's risk to that. If they're diabetic or hypertensive, we act differently. If the baby doesn't look good on the monitor, we act differently. So I had one of these moms we had a lot of moms that want very natural experiences that come with us, and I like that. But she was considering having a baby at home. She came in 9 centimeters. My partner ended up delivering her. There was horrible issues with a fetal heart tracing. They had to take her for an emergency C-section. And lo and behold, the baby had a TE fistula. So even though we're talking about things that are really not that common, if it's 1 in 5,000, if you're the 1 in 5,000, that's a 1 in 1. And this is something I feel people underestimate. This is not something we want to take any chances with. And having the care available, even if it's 5% have some aspiration, a very small percentage, having the ability to do ECMO, having the ability to diagnose the pulmonary hypertension in your facility is so important.
That's right, yeah. None of the families, or I guess the majority of the families that come to NICU were not expecting to come to the NICU. They were expecting to have a normal newborn experience. So yeah, I think the difficult things is, and the same as vaccines, the shift in perception of vaccines risks and benefits, we don't, the general population don't see what happens when things go wrong. And that happens, choosing how or where to give birth, and
Mhm.
and with other medical interventions as well. Yeah.
Yeah, we have a lot less patients wanting to take the Tdap vaccine because they associate it with the COVID vaccine. And like I understand now, we talk about the RSV vaccine that's coming through, which is a newer vaccine, but it's had some good health benefits for the babies once they're out. But there's such a huge distrust because of just the geopolitical issues with the vaccine itself, the COVID one, that it's interesting to see the patient's perceptions change and how that's happening. We're seeing more pertussis outbreaks. We're seeing a lot of other stuff. And for me, like for example, both my kids happen to be asthmatic. Both my kids happen to be admitted to the hospital at some point with RSV within the first 2 years of life. So if most of the time it's fine. And what I think people tend to have an issue agreeing with or saying is most of the time it's not an issue with that baby when we're trying to get something like herd immunity. It's about being strong as a group. And if once these things start seeping in, you start getting more pertussis, you start getting more RSV, the kids that are helpless, the ones with immune issues really start getting hurt.
Absolutely. And I think, just as a general comment, I think part of the patient's perception of not going through the standard medical care comes from the failure that we have as providers of informing them in a better way. You start, it has so much information, and once the algorithm kicks in, then that
Mhm.
reinforces your beliefs in a way.
For
and
sure.
and I think if you try to go in and see the side effects of the RSV vaccine, for example,
Mhm.
it's difficult. It's
Mhm.
hard to go to the NIH side and see how many of the women, the outside the journal publication that it's out there, which also is very scientifically written. So it's hard to communicate this outside our role as physician in our office. It's easier for other communicators in the social networks to transmit not evidence-based information.
It's not
But
sexy. It's not sexy.
it's not sexy. It's not sexy. Nothing's gonna happen probably, but you need this RSV shot. The RSV shot, and I I don't want to sound repetitive with miracles of research, but man, if you go to your winter season, even here in South Florida, which is hot, you go to the ER, the pediatric ER, 99% are kids with bronchiolitis from RSV. 99%. This RSV antibody in the pediatric population and the vaccine on pregnant women is game changer.
Mhm.
It has proven to decrease the ICU admissions on kids early in life by half. So half of these many children, the main infectious disease illness in pediatrics has cut in half, better than any antibiotic discovery.
Mhm.
So I think first we have to do better us in communicating this information and allowing the family to take a shared decision making with us to do best for their babies.
Yeah,
And
and to be clear, for me personally, I'm a very, very big believer in patient autonomy. They're going to choose to do whatever they want, but we have to inform them, and then they make the decision. I'm very pro the RSV for that reason, the vaccine. As you see that, actually, I was going to ask you because we've been talking about NICU stuff, but you're also a pediatrician now, doing concierge stuff. How long have you been doing the concierge, and what are the trends you've seen seeing these kids from the NICU on? Meaning
yeah,
in the
so
RSV and like just seeing these trends.
you know the RSV vaccine is so new. To answer your first question, my motivation to open the concierge practice came from saying goodbye to the families when they left the NICU and never seeing them again, except the random picture once a year. So and also how being with them during the months of NICU admissions
Mhm.
and being part of the care and becoming part of their family in a way. So when they left, Perhaps it's a very selfish reason to open a follow-up practice, but they say, no, I'm going to open a practice, but not a standard pediatric office. Now, unfortunately, pediatric has become such a rushed practice in a way when, where us pediatricians are pressured to see at least 20, 30 kids a day. And that means that we only spend 15 to 20 minutes at most with them. So I promised myself to open a practice, but to actually invest in not only giving them the shots, weighting them, measuring their length, but understanding how is the family situation at home, seeing how they're reaching their milestone, understanding how to help the family environment to maximize their development, and going to patients' homes, which is, I guess, the main thing that distinguish our practice from others. We do pediatric care at the comfort of the patients' homes, with no rush. So I see many babies that are born in NICU, and then I follow up because I'm a neonatologist. But also I see healthy newborn term babies, and I I think I echo what you said about the family's concerns of vaccinations. I see that trend a lot, and I think there's a big other trends that I see often is nutrition. There's a large trend on finding a better nutrition for children, which is a health, is a good thing. Families are becoming more conscious of reading labels. Before
Mhm.
we used to just give kids anything that said, kids product, and we used to feed them that. And now we're trying to be more conscious of what we give them. And also, I think having opened my practice, now I enjoy spending time with families a lot. So
Mhm.
that was the main motivation. The RSV vaccine, I think we haven't seen in the US information to really understand the effects.
Mhm.
The main information we're seeing is from Europe, which they have gone to the first RSV season. Many countries, as Spain, included the RSV vaccine as part of their regular vaccination schedule, and the vaccination rates are very high. So we can see actually in these countries that the vaccine has shown results that it promised, which is decrease the RSV admissions to the ICU, decrease the ER visits, and I think it's been very successful. We don't know yet the long-term effects. We don't know them, but that's why we consult families. We don't know the long-term effects. These types of vaccines are safe for families. We know the short and medium term, which is your child may not be admitted to the ICU because we give the vaccine. And I
Mhm.
think for now, the benefits outweigh the potential risk by far.
Yeah. Well, it's very true going into that. And no, it's also very interesting that you're now in people's houses. You get to see how these kids are raised. You get to see the situations that they're in. And people also tend to ask why concierge. We are not a concierge practice, but we're lucky we're part of a company that gives us a unique situation that we still can take insurances and see patients. If people go into our waiting room and they're like, you are there, there's way too many people there. You walk in and it's
Right.
completely full. Specifically primary care and pediatrics for the patients listening. They're like, well, that's selfish. Why are they doing that? And they just want money. It's not that. The issue is you have these pediatricians and also primary care doctors that went to through all this training to treat people, and now they're literally pushing paper, either having mid-level providers do all the work and signing papers, or they're just literally passing pills and not able to help people. And one of the main reasons I also wanted you on is because I can tell you share the sentiment. You can't see everyone. You can't help everyone. Actually, your time is very limited and you're seeing very few people. But those people you can help to a very high level. And I think through mediums like this, we can help a huge amount of people seeking information to make sure, hey, when they need a resource, they can come find it. They can hear what you just said about the RSV vaccine, see how you say it, see how you approach care. And if you are a right fit for them, great. But if not, they can bring that into their own practice. And we have the ability to help people. As bad as we're talking about Instagram influencers saying how bad a bunch of things are, we can on our end at least educate people and give people at least our perspective instead of getting the 1,000 to 1 of what's trendy on
Absolutely.
internet for the day. So I'm really happy that you started doing that. And you're in Aventura mostly area, correct?
I'm in Aventura. Most of my patients that wants us to go to their homes are in Miami Beach,
Mhm.
or in Sunny Isles. So we
Mhm.
have patients everywhere. We don't take many patients every year because I like to spend time with my patients. So, easily, because the service that we provide is so valued by the families, easily can turn into the 30 patients a day.
Mhm.
Unfortunately, I don't want that. I want to be happy with my practice and enjoy what I do. So I go to patients' home, which is the best environment. You see my office now. Some of the patients come here, but there's nothing better there's no better environment to understand childhood development and see children's milestones than seeing them play in their comfort of their home in a known environment. They are looser. They want to play. They want to interact with you. But here they come to my office and everything is white, and they see the fridge. They wonder if there's gonna be a shot there, and they
Mhm.
become more, I guess, yeah,
Very,
more worry. So, but in their homes, I see how they walk. I see how they interact. So it's a very fulfilling job for me. So
you can
I
definitely
love
make,
it.
and you can also definitely make a better assessment if possible.
Absolutely.
It's
Yeah,
yeah.
absolutely.
It it's funny, I think medicine's going so forward and so backwards at the same time, meaning, like, AI is taking over one end, and now people are going, "No, I wanna go back to how it was going house to house, spending time with people." My grandfather was a surgeon, by the way, and he's from Chile, and he had a when I'd visit, I would see he had his car, and he wasn't practicing at the time anymore, but he had a little trailer in the back of his car, and he used to go to the poor neighborhoods, one place to the other place, seeing people, and he'd be like, "Okay, you need medical care," and they'd barter, "Here's a chicken." You know what I mean? So it's interesting, like, I know it's different what you're doing, but it's kinda like the same thing. "Hey, let's take all the bullshit out of here, of all the insurance nonsense. I'm here to take care of you." And there it's a value proposition, and that's in both ways, and it's by keeping it small, you're also finding the patients that are a good fit for you, because I know from you, if the patient doesn't feel you're getting the same value that you're offering, it's not a right fit. You want those people to be a right fit. And I know, at least for a limited of time, you're considering just doing consultations with some people to see if you guys match, right?
That's right. Yeah, that's right. Yeah, well, because I do neonatology, I'm very familiar with what happens in the womb. So many of the expected mothers come to me to understand what you expect when the babies are born, from normal newborn to if there's a complication during pregnancy. I'm very comfortable doing that, and the for me, the fulfilling thing about that is that I get to know the families before the babies are around, and I can console them about what to expect, because you're a father. When
Mhm,
babies are born, just you lose it. You're
mhm,
tired, you're hungry, your wife is tired, your wife is
mhm,
hungry, you have to take care of another individual that you don't know what to do. And you go to the pediatrician and you want to go back home because you're tired. Your baby's a week old, and you don't want to listen to your pediatrician anymore. You want to think about how to prepare things. You just live in it,
mhm,
which is a good way to learn, and it's good for your pediatrician to be walking that path with you. But when mothers come here and the babies are not born yet, that's a good opportunity to establish a bond and to prepare families of what to expect. And yeah, and I think that if patients from your practice would like to reach out, I will be happy to help them through it.
perfect. No, it's a very good point. A lot of the videos and people I've been interviewing lately is very postpartum. These people have, which is good, they have a birth plan, they wanna do this, they wanna do that, and then, the baby's out, and they don't have no plan. And we always tell them to find a pediatrician, whoever it is, but learning how to take care of the baby, understanding that their family structure is changing. But if their pediatrician usually lets them talk to them, I'm like, hey, see if they're a right fit for you. You're with us because you feel like we bond. And a lot better to build relationships when you're not at your last. Like, don't
That's
push me
right.
because I'm close to the edge. I haven't slept in forever. When I walk into my
That's
office postpartum and their eyes look like my eyes because I was just post call, I'm like, hey, you get it now. So it's good, I
that's right.
think, that you do that. And also, you're still working as a neonatologist, right?
Yeah,
So it's
yeah.
you're still doing both things. You're always having the eye on research and doing the acute care, seeing those little preemie babies that you fell in love with to begin with, I guess.
Right.
If someone wanted to reach you, what would be the best way to do it?
So they can look us up. Our practice name is Sunbeam Pediatrics, or they can look us as Dr. Gaston Ofman on Instagram. They can just my practice information is there. And yeah, or they can reach out to you, and if any of your patients, you have my information in your office.
For sure.
But yeah,
I'm also going to cut up these videos into shorts for Instagram. I'll put both of our names there so they can just click your name and head over
Perfect.
to you. Awesome.
Right.
I really enjoyed this conversation.
All right.
Doing great.
Thank you for helping me.
Thanks for coming.